Good afternoon, everybody, and welcome to Parkinson's Academy Managing Bowels and Bladder Problems webinar. My name is Diga Hasters, and I will be chairing the first session. We have Sue Thomas speaking around the data and the importance of looking at the data and what that tells us about the importance of bladder and bowel management in Parkinson's. This will then be followed by Jane Young, who will be speaking about her experience of working in Central and North West London NHS Trust and how they support their patients with Parkinson's in bladder and bowel management. And then we'll finish off with Robin Fackrell, who will look into more details about the bladder and bowel dysfunction in Parkinson's. We will then have a very small comfort break, and we will then be followed by Professor Peter Jenner talking about the role of the glutamate in Parkinson's disease. We are very happy that you can join us this afternoon, and we are very pleased that this webinar is sponsored by Profile Pharma. So thank you to Profile for this. And just as a reminder to everybody, if you are interested in Parkinson's in more depth, we run Parkinson's Advanced Masterclass, which is coming up in May. We also have a Foundation Masterclass coming up in October. And if you haven't got the time to take up those, we also offer a fully virtual on-demand masterclass to take in your own time. So do visit our website, neurologyacademy.org, for more details. But without further ado, I will ask Sue Thomas to kick off this afternoon's session. Sue.
Thanks very much, Diga, and hopefully you can see my screen here. I'm going to set the scene on today and talk a little bit about bladder and bowel dysfunction, but it's something really that we don't discuss very easily. It's always been a bit of a taboo subject. And the data that you see here is from a YouGov research questionnaire that was done in 2016. And it follows along, I guess, in terms of how people have been embarrassed about their bladder and bowels for as long as I can remember. I was one of the advisors for the Continence Forum at the RCN for 18 years, and it was certainly something that there was a lot of stigma around talking about your bladder and bowels, and we were always trying to raise awareness of the importance of addressing bladder and bowel issues. But in that YouGov research, 1 in 5 people said that they were too embarrassed to talk to their GP about the fact that they got problems with their bladder and bowels. And a fifth of them said that they would try and sort out the problem themselves before seeking any help. 35% of people said that they would wait and see if the problem went away before they saw their GP. Put off today what you can do tomorrow, and then it just gets put off, and people carry on and plod on with the problem ad infinitum. 1 in 10 people said that they'd wait between 2 and 4 weeks before they spoke to their healthcare professional about a bladder and bowel problem. So, you know, it's not something that we discuss that easily. It's been likened to a problem with erectile dysfunction. It's just as problematic as discussing that. And I think that in terms of women particularly, a lot of women feel that it's an inevitability of getting older. You have children and you put a bit of strain on your pelvic floor. And if you get a bit of a problem in terms of leakage, then, you know, they think it's just inevitable and don't do anything about it. But of course, there is something that we can do about it. And it is something that as healthcare professionals, we should be talking about with our patients. Bladder and bowel issues are much more common than you think in Parkinson's disease. And this is just an illustration of the 4-stage management paradigm that Doug McMahon and I developed in 2008, where we used a diagnosis, maintenance, complex and palliative care scenario to explain about the care that patients would need when they got Parkinson's disease. But of course, prior to diagnosis, there is a prodromal stage where patients will be getting non-motor symptoms that might be suggestive of them developing Parkinson's disease. And one of those problems is constipation. So we can see from that schematic here that constipation comes right at the start of Parkinson's disease, and it should be something that we're thinking about really straight away from diagnosis, and trying to advise patients about, you know, the problems that they may get as a result of the condition. Just in terms of the cost of constipation, and sticking with bowels for the moment, always an interesting subject here, but if we start to look at data, there is a huge cost to managing constipation in England. I think it's quite shocking. But in 2017-18, 71,500 people almost were admitted into hospital with constipation. That's 196 people a day. And that's not really something that you would expect people to be admitted into hospital with. In 2018-19, that had gone up to nearly 77,000 people, 211 people a day. Of those, 3/4 of them, 55,500, were unplanned emergency admissions. So that's 150 people a day, and 60% of them were women. So you can see the extent of the problem there. That's, you know, a huge issue. And this is data that comes from the Bowel Interest Group, BIG. They've done a cost of constipation publication every couple of years. And that's just showing exactly how much the rate of constipation is going up. In terms of costs, this is a significant amount of money. £168 million was spent by the NHS in 2018-19 on managing constipation. And if you look at that in terms of funding nurses, that would fund 7,304 nurses, newly qualified RGNs. We could do with that amount of nurses in our workforce at the moment. So if you think if we could get constipation under control and save a little bit of this money, think how many more nurse posts we'd be able to put into the NHS. Just in terms of that total cost in emergency admissions, that was £81 million. So again, a huge amount of money that is being spent there on the cost of managing people's bowels. I've been collating hospital episode statistics since about 2014, looking annually at what's happening to patients with Parkinson's disease and why they're going into hospital, in an effort to try and understand what the predictors of hospital admission are, so that we can do something about it. And this is some data that I collated in 2019-20. It's secondary care data. It's taken from the hospital episode statistics database that NHS England produce. As you may be aware, we have to record when patients go into hospital with HES data, why they're going in, the reason for that, so that we can obviously look at what the trends are, and also through what was payment by results, get paid for the care that patients are being given in hospital. And in 2019-20, we got 121,000 patients with Parkinson's in England. And of those, 77,308 went into hospital as an emergency admission. That was 2 in 5 people with Parkinson's. And emergency care, where people go into hospital as an emergency admission rather than an elective, it accounts for 68% of all Parkinson's admissions, and nearly 85% of the total costs of people going into hospital with Parkinson's. When you start to drill down on those statistics, you'll find that the majority of the reasons why people are going into hospital if they've got Parkinson's are bladder related, with things like urinary tract infections, falls, very often as well, people getting up in the middle of the night to go to the loo. So again, it's, you know, bladder and bowels related there, but falls tipping people into hospital, lobar pneumonia and sepsis. And again, you know, we've got some quite high costs there. So just for one emergency admission for a patient with Parkinson's going into hospital in that year, it costs £3,889 per patient. And those patients were in hospital for an average length of stay of 10.3 days. Considerable length of time there. and at a total cost of people going into hospital of £301 million. So again, a huge amount of money. And when you break that down into the top reasons for admission, we've got £26 million being spent on urinary tract infections, £18 million on falls, £19 million on lobar pneumonia, and then £15 million on sepsis. And some of the instances of sepsis, again, from that admissions data that we analysed, were sepsis related to UTIs, so as a secondary cause of a UTI infection. And if we look at the trends in data, so as I said, I've been collating this data for some years now, we can see how that's changed over time. So when I first started collating this in 2015-16, we had £119 million worth of admissions for Parkinson's disease going into hospital. Again, 67% of Parkinson's admissions and 72% of those costs were related to a Parkinson's hospital admission. 11.8 days of an average length of stay there. Moving on from that, just a few years, that cost has gone up phenomenally from £119 million to £301 million. Just a slight drop in the number of days there, 10.3 average length of stay. But again, you can see that, you know, those costs are huge in comparison to, you know, managing patients. If we could manage to keep them at home and look after them properly and try and alleviate problems like constipation and bladder and bowel issues, we would make a tremendous saving there. Even though we've been flagging this year on year, we still don't seem to have got any abatement at all in terms of those admissions. So I think that, you know, bladder and bowel issues are something that we really ought to be focusing on, if at all possible. I think that one of the things that we need to do really is try and take the stigma out of handling bladder and bowel issues and try and make it acceptable for patients to, you know, bring the problem up with us and for us as nurses and clinicians to be able to speak to people about it. And there are lots of ways that we can do this. And in terms of the non-motor symptom questionnaire, if you're managing people with Parkinson's, very often you'll use NMS Quest as a pre-questionnaire before they come to clinic to have a chat with you, or it could be sent out to them for a remote consultation. But if you look on NMS Quest, you'll see that there are the problems that are associated with Parkinson's in there. I was very fortunate to be on the original steering group with Ray Chowdhury, who set the NMS questionnaire up, and one of the main areas that I gave input to that questionnaire was around bladder and bowel management in the early days when we put the questionnaire together. But that questionnaire is there. There is no stigma attached to it. If patients complete it before they come to clinic, they can tick the boxes that they've got problems with and enable you to actually bring the issues up with them in a non-stigmatized way. And there's also some helpful literature at Parkinson's UK, looking after your bladder and bowels in Parkinson's. It's got some really useful information in there. I think, you know, some of the time in terms of patients having problems with their bladder and bowel, it may be a functional issue, not being able to get to the toilet in time, needing modified clothing in order to get to the toilet. And I'm sure Jane's going to bring some of this up when she speaks to us. But, you know, there are means and ways in order to help people, you know, that I think that would be beneficial for us all to be able to have a look at. Just on the left of the screen, just going back to the bowel interest group, the big report that came out earlier this year, is the cost of bowel dysfunction here. And what that report has done is been able to look at the variation in the rate of admissions for into hospital for constipation and colour code those so that we can see which are the areas that have got the highest number of people going into hospital with constipation. And you can see from this up here in the northeast, we've got quite a high density there of people going into hospital. Down here, lower in Cornwall and Isles of Scilly. But it gives you some idea to have a look at what the problems are so that, you know, you can see what's happening in your region. and how you might be able to work with your local providers to try and do something for patients. So just in summary, I think we need to recognise that bladder and bowel problems are very distressing, they're costly, have a real impact on quality of life for patients. With an appropriate assessment and intervention, we can usually find a solution for management. And it's a win-win situation if we manage them well. So hopefully with the other speakers that we've got today, you'll get some guidance on how to manage bladder and bowel in Parkinson's, and we'll be able to support our patients in a much better way. So thank you for your attention. And I think I'm passing over now to Jane to do her talk.
Thanks, Sue. That was really interesting. And thank you for inviting me to speak today. I'm very passionate about neurological bladder and bowel dysfunction. And obviously, as you might expect, we see an awful lot of patients with Parkinson's disease, and predominant constipation, but some bladder issues as well. So a little bit about our service. I've been in this particular role for 11 years, although I've been in bladder and bowel management for 27 years now. And I manage a team, 7 nurses, including myself, across 3 CCGs, and we have an adult bladder and bowel service. We do lots of clinics and home visits, ambulant catheter changes, housebound TWOCs. We've got a catheter nurse specialist that does catheter SOSs, and obviously we've got KPIs that we need to meet. But I think crucially for our services, we have a self-referral process, which takes away that stigma and that, you know, that embarrassment and shame that Sue talked about, and you know, not having to go and perhaps discuss this with a GP first. So yeah, we get lots of self-referrals from patients, and obviously we've honed this service over the last 11 years to meet the needs of the service. Obviously, we work very closely with our secondary care colleagues in both neurology and neurology. And actually, in 2018, we did an audit of our patients within just the borough of Hillingdon, 300 patients, quite a poor response, as you can see, which sort of, you know, perhaps put down to the cognitive decline that Parkinson's patients suffer with. And it came back that 90% of patients with Parkinson's in Hillingdon were suffering with constipation. Interestingly, quite lower than sort of what research suggests, only 42% of them suffered pre-diagnosis. Up to 71 patients were not aware they could self-refer, so that obviously gave us a platform to inform patients that that service was available. And interestingly, 97% of patients wanted a one-to-one because we offered them, if they needed advice and support, either a one-to-one or a group sort of health promotion session. So just highlighting how, as Sue alluded to, embarrassed patients are and they don't want to sort of discuss this. So constipation, as per the Rome criteria or definition, is less than 3 bowel movements per week, and it's often associated with straining, digitation, and generally feeling bloated and having abdominal discomfort. And we know that constipation, from the plethora of research out there, is one of the most prevalent non-motor symptoms in patients with, so, you know, research varies, but, you know, the statistics that I've looked at vary from 20 to nearly 90% of patients reporting constipation as a predominant symptom. And obviously then that's increasing with the progression of the disease, and it can occur up to 10 years before diagnosis or motor symptoms occurring. And we know that in Parkinson's, this is largely due to the dysregulation of the brain-gut microbiota axis. So essentially, we all know that, you know, it's widely regarded that Parkinson's disease sort of is initiated in the enteric nervous system, which we know can sort of function autonomically. It doesn't need that communication between the central nervous system. It can function on its own, but it's when those 2 nervous systems aren't communicating in a coordinated way that we get this dysregulation, which then leads to that reduction of the GI transit. So slowing down the transit time from mouth to anus. And we know that there's lots of papers out there that talk about the anorectal dysfunction that the the Parkinson's patients will experience. So, you know, they'll have failure of the puborectalis muscle to relax, and a lower expulsion of feces from the rectum. They just haven't got that pressure. And that obviously is combined with inadequate and delayed absorption of the oral anti-Parkinson's medications. So, you know, obviously that's going to have a negative impact on both the gut and also the Parkinson's symptoms. As Sue alluded to, it is underreported, as with most bladder and bowel dysfunction, due to the embarrassment factor, but it has a massive impact on quality of life. And like a lot of our spinal cord patients, you know, Parkinson's patients will say that, you know, they could cope with the Parkinson's. It's the bladder and bowel issues that are so, you know, have such a big impact on quality of life. And I think for that reason, these patients do need regular support. And I know myself that, you know, Parkinson's disease related constipation requires much more input than other perhaps neurological patients or those with just slow transit constipation. So lots of options that we can offer these patients when they're suffering with constipation. And I think, you know, Parkinson's patients are well known to have poor fluid intake, perhaps not such a great diet. So don't underestimate things like synthetic fibres for those that have got a low fibre diet. We know from research that magrogols are particularly good for Parkinson's disease constipation, along with drugs like lubiprostone, bisacodyl, prucalopride. So these are obviously stimulant laxatives, increasing gut motility. And then there may be patients that need that anorectal interventions like suppositories. I have done anal irrigation with quite a few Parkinson's disease patients where you're not getting a satisfactory anorectal evacuation. There is research to say that multi-strain probiotics can be particularly helpful with Parkinson's disease, so we do recommend those to most patients with constipation, actually. And then for those patients that have that dyssynergia, that failure of the puborectalis muscle to relax surgically, our acute care colleagues would offer Botox or apomorphine injections into that puborectalis muscle. Obviously, all of these Parkinson's patients are at risk of bladder dysfunction secondary to their constipation, but also just as, you know, part of the aging process and suffering with other comorbidities. So take into account, you know, that they are at risk of constipation due to prostate enlargement in women, anterior prolapse of the bladder or uterus, uterine fibroids in women, and obviously antimuscarinic use. And I think we really need to be careful with Parkinson's patients and our elderly patients because of the anticholinergic burden. But, you know, certainly we would never advocate putting any Parkinson's patient on an antimuscarinic without a bladder scan before and then afterwards as well. And I'm sure this will come up a lot in the questions because nocturia is a massive issue for the elderly and frail, but also, you know, impounded really by Parkinson's disease. And we know it's a massive falls risk if patients are actually able to leave the bed, because a lot of them aren't and become reliant on pads overnight, even though they may not have any physiological need. But also then you get the compounded fatigue due to the nocturia, which incidentally is more than 3 times at night, needing to void. Urinary tract infection obviously could be secondary to chronic retention or poor hygiene, but it also in Parkinson's patients, it's related to poor swallowing, you know, not really having the urge to drink and needing constant prompting to drink by carers or relatives. Overactive bladder obviously is hugely an issue for you know, our elderly patients, certainly our middle-aged postmenopausal women, but, you know, again compounded with the Parkinson's issues, risk of falls overnight, and nocturia. And Robin's going to talk more about treatment for that. And then our patients, as I said, with mobility issues will have that functional urge incontinence, not being able to get to the toilet on time, reliance on pads when otherwise they have sort of normal control of their bladder, but there's just that functional issue. And then obviously comorbidities such as heart failure, and Robin's going to talk more about management of nocturia later on. So in summary, I think it's really important that these Parkinson's patients have access to a specialist adult bladder and bowel clinic, and I think, you know, the ones that allow self-referral will have more chance of reaching these patients. I think it's really important that local bladder and bowel services, you know, do link up with their local neuro rehab teams, their Parkinson's nurse specialists in the acute sector in the community, so that we can all work together. And I'm sure you'll agree that bladder and bowel dysfunction is as important as managing motor symptoms. I hope you've enjoyed my talk. Thank you.
Good afternoon. Thank you very much for inviting me to speak. My name's Robin Thackrell. I'm a consultant geriatrician and specialist in Parkinson's disease and related disorders in the Southwest in Bath. I'm passionate about the management of Parkinson's disease, but moreover, non-motor symptoms and bladder and bowel dysfunction. And I think I echo everything that my previous speakers have said about, if you don't ask, you're not necessarily going to be told about these symptoms, as people find that they're quite embarrassing to talk about. But if you normalize it early on in your relationship with the patient, then it will be just part of your consultation, and they will be expecting it, and they'll be then only too happy to share the details of their bowel and urinary dysfunction, or hopefully function. Just trying to get my slides to move on. There we go. So the essay on the shaking palsy was written in 1817 by James Parkinson. This is an illustration by William Gower, and I just wanted to just sort of say that this shows you what you see when the patient walks into the room. And you can see there the forwardly flexed posture. You could almost suggest that there might be a bit of a tremor there, a bit of rigidity, slowness of movement, postural instability with that forwardly flexed posture. But what you can't see is the bowel dysfunction, and you can't see the fact that he might be incontinent or that he's having difficulty with nocturia. And unless you ask him, he won't volunteer those issues. So as we know, Parkinson's is so much more than just a movement disorder, as it keeps getting referred to. It's not just a movement disorder. Well, sure it is, but it's everything else that goes along with it. And often the non-motor symptoms of Parkinson's are a greater source of disability to our patients. And that can be independent of their motor function. So their motor function may be great, but their bladder and bowel dysfunction may be causing them great distress and really reducing quality of life for them, reducing their ability to socialize, interact, affecting their relationships, etc. And bladder and bowel dysfunction is pretty universal in our patient group. So we do need to be assessing it at every interaction that we have with them. And I think, just to echo a point that I think Sue made earlier, is that these symptoms can often be sort of difficult to raise, and actually patients might see them as primary complaints or inevitable, part of aging, for example. And unless you kind of normalize that and allow them to see it as part of the Parkinson's syndrome, then they won't volunteer it. So I think we just need to be thinking about this and asking about it at every interaction. So just starting with bladder control. Bladder control is really, really complex, and you know, I haven't sought to go into this in this short talk in great detail, but you can see that there's a lot of areas of the brain that are related with the storage of urine, from the hypothalamus, the frontal cortex, the basal ganglia, crucially, and the cerebellum. And quite often, as people age, a degree of latent small vessel ischemic change within the brain can lead to challenges with bladder storage and voiding anyway. So you have the pontine storage center and the pontine voiding center, the micturition center, and that's also supported by the prefrontal cortex and the hypothalamus. And crucially, again, the basal ganglia, which obviously is involved with Parkinson's disease, is involved in inhibiting detrusor. And so detrusor overactivity is a very common symptom, and that can predate the onset of motor Parkinsonism. So as everyone's aware, the lower urinary tract consists of two major parts, doesn't it? The bladder and the urethra. So the bladder has a lot of muscarinic receptors, and you can look at and see how we treat it to understand this further, and beta-3 receptors, and we'll come on to why beta-3 receptors are important. And it's innervated by cholinergic for the parasympathetic and noradrenergic for the sympathetic fibers for contraction and relaxation consecutively. And the urethra has abundant alpha and nicotinic receptors, adrenergic and nicotinic receptors, and also is innervated by noradrenergic and cholinergic fibers. So in terms of storage symptoms, as Parkinson's disease advances, the inhibitory effect of dopamine on detrusor decreases. So that gives rise to the symptoms of detrusor overactivity. And you'll be familiar with these symptoms in your patients. So they normally describe of urgency and frequency. When they got to go, they got to go. They need to know where all the toilets are. Also nocturnal frequency, more than 3 times a night. So really fragmenting sleep. And this is a crucial symptom because you spend a third of your life asleep. If you have poor sleep, that affects your cognition. It also affects your rate of falls, etc. People have their worst Parkinson's control at night, don't they, when they're just on controlled release or low dose dopamine. And so if they're getting up a lot at night, that's when they fall, that's when they fracture, that's when they go into hospital. So really focusing on these symptoms is really important. And obviously urgency and incontinence. Incontinence in itself can be a major reason why people enter residential care, for example, or lose independence. So it's really important that we get on top of these symptoms. So voiding symptoms occur in Parkinson's, but they are less common than the others. But PD patients do have higher rates of slower initiation of urine, poor urinary stream, although as men age with their prostatic hypertrophy, they can have poor stream as well, and also straining. And there's often a correlation between voiding symptoms and the stage of Parkinson's. As people develop more complex Parkinson's, they tend to have greater degree of voiding issues. But despite that, despite their difficulties voiding, Parkinson's patients, when you bladder scan them, and just to pick up on Jane's point, bladder scanning is really important. Just sort of putting your finger in the air and guessing is probably not the right thing to do, although it's better than doing nothing. But doing a bladder scan is important. But they have low post-void residual volumes. And if you're noticing that your patients have high post-void residual volumes, then we do need to think about other diagnoses being present. And MSA is one of the conditions that might lead to that. Of course, there are others. So treatment of bladder dysfunction, the first thing you need to do is ask. The second thing you need to do is take a detailed history about what's actually going on and investigate appropriately. And I think that it's almost impossible to make good diagnoses without doing urodynamic studies, without doing a bladder scan at the very least, and correlating that with patient symptoms. Just talking about how levodopa and dopaminergic therapies are inhibitory on detrusor, optimizing dopaminergic treatment is really important. So sometimes patients have the urgency and frequency when they wear off. And so it's important that their dopaminergic therapy is as good as it can be at the outset. And I think, educating them as to how they can best manage their symptoms non-pharmacologically is also really, really important. When it comes to thinking of reaching for the prescription pad, we do need to be thinking about patient choice and what they want. And I fundamentally believe in informed consent around these treatments. Jane mentioned the anticholinergic burden, and I cannot stress this enough, that anticholinergic drugs are dangerous and toxic for patients. And we really need to be careful when we're giving them, particularly to our frailer patients, cognitively and more physically frail patients. If you look at acbcalc.com, it gives you a really good anticholinergic burden score. Oxybutynin, for example, is in my view, a terrible drug, and it causes, it stop you peeing, but it'll also make you fall over and increase your risk of dementia. Anticholinergic medications, tolterodine, trospium and solifenacin are a little bit better, but we do need to be thinking about the legacy of these treatments and how they might affect our patients' cognition, their falls, their rate of death, all go up with anticholinergics. And things that people don't necessarily know about anticholinergics is the lesser anticholinergic medications like furosemide and atenolol and all those things. So if there's an aggregate of sort of polypharmacy, as patients tend to get as they age, and with Parkinson's disease, they can often be on 7 or 8 different medications. The anticholinergic load goes up. And if we just stick another one, which is potently anticholinergic on top, we cause a big problem. I'm going to get off that soapbox now, otherwise I'll just keep going. So I advocate mirabegron, and in certain areas, particularly with cognitively frail, this is the first go-to medication in people with neurodegeneration. And I find that it's much better tolerated and effective. But if you remember the innovation of the bladder, it's not only beta-3, it's also the muscarinic receptors. So we do sometimes need to combine treatments, but also let's think about using our urologists. That we underuse urology colleagues for the management of bladder dysfunction in Parkinson's disease, and they admit that they are underused. Urinary Botox is something as well that can be useful for patients. Nocturnal polyuria in Parkinson's disease, we do see quite a high, and again, if you don't ask the question and you don't investigate and you don't measure the urines, you won't diagnose this as often as it might be. We know that Parkinson's is involved with change in natriuretic peptide and ADH production, and this increases the risk of nocturnal polyuria. So that's defined as passing more than 50% of your 24-hour urine volume between your sort of nighttime hours, or a nighttime urine production of 0.9 mils a minute or greater. So the only way that you can sort that out is by doing a 24-hour urine collection and actually giving somebody a big bottle and measuring their urine. That can be difficult for some patients. So sometimes the history is important, but if they are voiding the majority of their urine volume overnight in big volumes, so some people go through diffuser hyperreactivity and they only go small amounts but very, very frequently. But if they're voiding a lot and greater than they do during the day, then we really need to be thinking about nocturnal polyuria. And the reason for that is because it responds really well to desmopressin therapy, and people can actually really improve, get a much better quality of sleep, and then have a much better motor function and cognitive function the next day as a result. So bowel dysfunction, I've just got to say constipation. It's so important because it's universal, and it affects the way that patients, their quality of life, it affects everything. And we want to avoid this. This is a patient's abdomen that was prescribed, it had Parkinson's disease, quite a complex Parkinson's disease, was prescribed tramadol at relatively high dose following a wrist fracture. They had complete gastric outflow obstruction, and they were admitted unconscious because they weren't absorbing their medications. And they quickly responded to reticuttine, but they had to have surgical decompression of their gut. So we want to avoid this. It's unnecessary, so we need to be thinking about constipation in all our patients. It's really, really common, and the increased mouth to anus transit time leads to erratic absorption and therefore unpredictability, and patients can have unnecessarily increased doses, for example, when all they need to ensure that they get have a regular soft bowel movement every day or every other day. And just thinking, if you've ever been constipated, the bloating, the pain, the nausea, if that's happening to you daily, the quality of life impact is huge. And so it's a symptom that we can rapidly help with. So why does it happen? Well, as people age and if they have neurodegenerative disorder, they have a weakened abdominal musculature. We know that actually Parkinson's patients have a lower water intake. And so I'm constantly encouraging my patients to drink water, as much as to say that as part of the treatment is that they need to have a full glass of water with each medication, because otherwise they are underhydrated and like prunes, the majority of them. They also take less fiber compared to their age-matched controls, strangely, and so increasing fiber, you know, golden linseed, those kinds of things as natural laxatives and those kinds of things, and dietary fibers and synthetic fibers is important. And we've talked about the paradoxical increase in sphincter activity that can occur. So how do we treat constipation? Well, we need to decrease off time. The anticholinergics, again, I'm going to mention that again, is that one of their big side effects is constipation. And so reviewing that and trying to reduce it if at all possible. Fluids, we need to make it part of somebody's routine, encouraging them to move, because that will help their bowel move. Just one thing I've asterisked the macro goal. The reason I've asterisked that is to remind me that quite a lot of our patients, particularly the frailer ones, don't drink very much anyway. And if all they're drinking is laxative, then that's not very pleasant for them. And so we have to think about different ways rather than just giving them increasing sachets of Laxido sometimes. We've talked about, or James mentioned, apomorphine for rectal dyssynergia and Botox to puborectalis sometimes. But in essence, if we get on top of it earlier, with the exception of the apomorphine, we should be able to prevent most of these things occurring. I also want to just touch on acute bowel dysfunction, because patients with Parkinson's disease are at much greater risk of sigmoid volvulus, which, as you'll be aware, is a twisting of the sigmoid colon around the mesenteric axis, which risks bowel ischemia and death of the bowel, which is a life-threatening surgical emergency, which has a very high mortality. And it has this very classic coffee bean appearance on X-ray. It's treatable with endoscopic sort of decompression of the bowel, or something called a PEC. But the reason why we need to keep on top of constipation is to try to reduce the risk of this kind of thing occurring. And the use of laxatives and things like proculopride, which Jane mentioned, can help people reduce their risk of sigmoid volvulus. But it's also just to recognize this is an increased risk, and if you're noticing these kinds of X-ray appearances, that's an acute emergency situation. I'm going to stop there. Thanks very much for your attention. I'm very happy to take any questions.
Thank you very much. The 3 degrees, can I call you that? I don't know if I can, but I just have. That was really, really excellent. We have questions that have come in. One's come in through the chat option, which is, where can people find the anticholinergic burden score?
Okay, I can take that one. So
thank you, Robin.
www.acbcalc.com. That gives you a direct, we can put that in the chat box, I should think, and that gives you direct access to a website where you can see most prescribed medications and their anticholinergicity, if that's a word, and you can then calculate the risk that a patient has based on that. And things like oxybutynin, tolterodine, etc., have a score of 3, furosemide, atenolol, etc., have a score of 1, and you can tot it all up and see what the overall burden of the anticholinergic drugs are.
Brilliant. Thank you, Robin. A question for you, Jane, I think, from Katie Rigg. Should all continence teams offer bladder and bowel management support? So many seem to address bladder issues, but rarely support people with their bowel issues.
In my opinion, yes. I mean, we've come a long way. As Sue will remember, we rarely call ourselves continence advisors anymore. I call myself a bladder and bowel nurse specialist, because one is as important as the other. They're right next door to each other anatomically. So yeah, I think any decent bladder and bowel service should provide support for bladder and bowel dysfunction.
Thank you, Jane. I think this one's for you, Robin. What do you determine as a low or high PMV?
Ah,
Aha.
that's so it's tricky. I mean, I think you have to do it by symptoms, but also it's a rule of thirds, really, isn't it? It depends how much people are avoiding, so what their pre-micturition bladder volume is and what their post-micturition bladder volume is. There are numbers associated with this, and Jane, have you got numbers that you draw upon, or in terms of the number that when we think is too high and is not too high?
Yeah, I think typically urologists will say sort of anything above 150, you know, but personally I go on renal function, symptoms, and residual urine, and it's looking at all those three areas, because you can have someone with a really high residual. I've got a chap in Hillingdon with 900 mils, completely asymptomatic, completely normal renal function, no hydronephrosis, no UTI, so it is really individual.
Yes,
yeah, but 150 plus.
Yeah.
Okay, so we are running out of time, but I've got one more question. I'm going to double up on two questions, one from Zoe Hemsley and one from Katie Rigg again, which is about desmopressin, and should this be used, or are there any reasons why it shouldn't be used in PD or MSA, and if it can be used, what should the dose be, please? Robin?
So is there a reason why it shouldn't be used? No, I mean, if their electrolytes are okay, there is no real reason why you shouldn't trial it. Jane, have you got any other view?
Yeah, no, I think I don't use it that often because of the great faff in terms of monitoring renal function very closely in these patients. But yeah, I can literally think of one patient in the last few years. You've probably used it much more than me, Robin. I tend to use the conservative methods, like, you know, with fluid reduction, manipulation of output with small doses of frusemide, like, you know, leg elevation in the day, caffeine avoidance. But yeah, but it's out there, you know, and it's nice recommended for us to use. So
in terms of the dose, this is one I always have to I always go back to the BNF to look at. But you can, you know, it's sort of 200 to 400 micrograms is the normal dosing, I think. But I will check back in, and I will, if that is the incorrect dose, I will put it back in the chat box. But yeah, it's around that I normally start.
Brilliant. Well, thank you, Sue, Jane and Robin, for the first part. I think that was really, really interesting. Lots of questions that we didn't get to. Hopefully we can save those and see how we can answer those outside of this webinar. We're now going to have a 3-minute comfort break before Professor Peter Jenner does his talk. So 3-minute comfort break, and I'll see you back here. Thank you.